So the main uses that we think about are determining gestational age, or estimating the due date, estimating fetal weight and percentile. But as I'm sure you know, measurements play an important role in many aspects of obstetrical ultrasound. And in particular, they diagnose or contribute to the diagnosis of many things: early pregnancy failure, as you heard, fetal growth abnormalities, assessment of fluid volume, and many other things. Since I only have 30 minutes, or actually 25 minutes because of the SAMs in the last 5 minutes, I will cover a fair number of these, but each one of them very briefly, to give you an overview of some of the key uses of measurements in obstetrical ultrasound. So one of the important things to think about is, since we want to follow guidelines of major societies, what are the guidelines that are out there with respect to measurements? So the American Institute of Ultrasound and Medicine, the American College of Radiology, American College of OBGYN get together on the obstetrical ultrasound guidelines. And so there's one single set of guidelines from those various societies. And what I'll show you on the next 2 slides is an excerpt from the OB guidelines that refer to measurements. So in the first trimester, these guidelines say that the crown rump length should be recorded when possible. The mean sac diameter may be recorded when the embryo is not identified. And the nuchal translucency should be measured in conjunction with the serum biochemistry during a specific age interval for those patients desiring to assess their individual risk of aneuploidy. So somewhat vague statement about when it should be used, suggesting that it should be used in conjunction with serum biochemistry. In the second and third trimesters, the guidelines talk about a number, some more uses of measurements than in the first trimester, including assessment of amniotic fluid volume, gestational age determination, weight estimation, and they suggest that the nuchal fold may be helpful during a specific age interval. So that's what's in the guidelines. Let me delve into some of the uses over the next, over the length of time of my talk. So first, briefly, determination of gestational age, or estimating the due date, is certainly a use of obstetrical ultrasound. And what I'll talk about here comes from a committee opinion that was jointly from the ACOG, AIUM, and Society for Maternal Fetal Medicine that talked about methods for estimating the due date. One thing that I would say is that every ultrasound should have every report of an ultrasound should have some statement about your best estimate of gestational age at the time of the ultrasound. So how can we use ultrasound to assign gestational age? And as you'll see in a moment, what I'm really talking about is how do we use ultrasound to assign gestational age at the time of the first ultrasound in a pregnancy, because that's the only time that you should use ultrasound to assign gestational age, as we'll come to in a minute. So if you see a gestational sac with no identifiable embryo, which would be the normal finding before 6 weeks, between 5 and 6 weeks, you can either assign the gestational age via the mean sac diameter or via the sac contents. Actually, in our institution, we don't use the mean sac diameter for much of anything, or especially for assigning gestational age. If we're doing a transvaginal ultrasound and we see a gestational sac with no yolk sac, we say our best estimate is that we're looking at a 5-week pregnancy. If we see a gestational sac with no identifiable embryo, but we do see a yolk sac, our best estimate is 5.5 weeks. Once you see the embryo for the rest of the first trimester, the crown rump length is the best method for assigning gestational age. And the assignment of gestational age in the first trimester is very accurate, to within about 3 to 5 days, plus or minus, which is very, very accurate. In the second and third trimester, the methods that you can use include the biparietal diameter, the head circumference, or the occipitofrontal diameter, and or the femur length. And if you can see all the way around the head, in other words, you can either do a circumference all the way around it or measure the biparietal diameter, the width, and the occipitofrontal diameter. The most accurate estimator of gestational age is to use head measurements, and to use a head measurement that accounts for the head shape, either the head circumference or something called the corrected biparietal diameter. I don't have time to get into it here, but it's a method of correcting the biparietal diameter for the length of the head. In many cases, especially in the third trimester, especially in the later part of the third trimester, it's very hard to see the entire perimeter of the head. Often you can measure the width but not the length. In those cases, when the biparietal diameter is measurable but the occipitofrontal isn't, because you don't see the full length of the head, either the biparietal diameter or the femur length is pretty good, not quite as good as head measurements that account for head shape, but maybe all that you can do. The accuracy gets worse and worse as pregnancy progresses. It's about plus or minus 1 point, just over 1 week in the early second trimester to a not very good plus or minus 3 weeks in the third trimester. One thing that's important to point out is the abdominal diameter or circumference is not reliable for estimating or determining gestational age. There's too much variability from fetus to fetus at any given gestational age in their abdominal diameter for it to be a useful method for determining age. So, what are the, from the paper that I showed on the couple of slides back, what are the recommendations for assigning gestational age? At the time of the initial ultrasound, at least the initial ultrasound after 6 weeks, they suggest basing the gestational age on the LMP unless the woman is unsure of her LMP, or if she tells you her LMP, but the LMP is inconsistent with ultrasound dating. And what do they mean by that? If you have an age by LMP that's less than 9 weeks, and there's more than a 5-day discrepancy between the LMP date and the ultrasound date, use the ultrasound date. If it's within 5 days, use the LMP. And similarly, for each age by LMP, there is a age range such that if there's more of a discrepancy than what you see on the right-hand side, use the ultrasound. If there's less of a discrepancy, use the LMP. But very, very importantly, and this is probably the most important single statement I'm going to make during the whole talk, don't redate pregnancies, or at least redate them in very rare circumstances, basically never. In other words, so what do I mean? If a woman comes in and based on whatever criteria we use, we come up with a gestational age of 10 weeks. Say via the crown rump length. If she comes back 8 weeks later, she's 18 weeks. Doesn't matter what your ultrasound measurements show, she's 18 weeks. You don't redate. So at the time of the 18-week ultrasound, you want to make sure the body parts are appropriate in size for 18 weeks, but don't redate them. Don't redate the pregnancy. So the only time we use ultrasound to date a pregnancy is at the initial ultrasound during a pregnancy. And in pregnancies achieved via assisted reproductive technologies like IVF, use dating derived from the technique, for example, using the embryo age and the transfer date in IVF patients, not the ultrasound measurements. What about estimating fetal weight and weight percentile? Basically, if you add body parts from 1 to 2 to 3 to 4 to 5, you get increasing accuracy up to 3. And then if people have, namely, using measurements of the head, abdomen, and femur. You can find papers out there that throw in 4th and 5th measurements like the thigh circumference and so on, but it doesn't really buy you more accuracy. So the best way to estimate fetal weight is via measurements of the head, abdomen, and femur. Once you have an estimate of the fetal weight and you know your best estimate of gestational age, based generally on a first trimester ultrasound these days, assess the fetal size in relation to the age to get via the estimated fetal weight percentile, and if it's less than the 10th percentile, suspect growth restriction, and then you have to head off on a course of assessment for that, attempting to determine the cause of small size and monitor closely. How do you come up with a weight percentile? You can use a weight table. So for example, if you have a 25-week gestational age and an estimated weight of 600 grams, you would see that it's between the 25th and 50th percentile. So you can use a weight table, you can use a weight chart, or use some sort of computer calculation, either a computer inside the ultrasound machine or separate from it, depending on how you do your reporting and interpretation. Very, very important that the abdominal diameter or circumference measurement, when you do it, to make sure the calipers are on the skin surface. Ideally, you want to see the skin surface around all or almost all of the abdomen. It should be as round as possible. See the stomach, the portal vein, often the left portal vein will be in view. But importantly is put the cursors on the skin surface, not on a rib, which I sometimes see people do. And really importantly, this is one of the most important measurements I'm going to talk about because it's it's the measurement that I see more often than not done poorly. These two images, believe it or not, here you can actually see the skin surface and the measurement was done inside, not on the skin surface. And here's another one where somebody put cursors in the middle of nowhere when you have no idea where the skin surface is. You can barely see that you're looking at fetal abdomen. If you wonder where I got these cases, those are both from malpractice cases where the estimated weight was grossly underestimated, leading to problems at delivery and serious complications after birth for the baby. So measure very carefully and importantly put the calipers on the skin surface. Okay, so age and weight aren't the only things by any means that we use ultrasound for. You heard on the prior talk about measurements in the diagnosis of early pregnancy failure or miscarriage, and there are criteria for pregnancy failure that use measurements and other criteria. I'll focus on the next several slides and very briefly on the measurement criteria: crown rump length 7 millimeters or greater and no embryonic heartbeat, or a mean sac diameter of 25 millimeters and no visible embryo, are measurement criteria for definitive for pregnancy failure. Findings that are suspicious, you heard in the prior talk, also include some measurement criteria and some that are not measurement criteria. And then there are findings that are suspicious for impending pregnancy failure when you see a heartbeat, some of which, again, use measurements: a slow or irregular embryonic heart rate, a large yolk sac, or a small gestational sac size. Even if there is a heartbeat, if you see any of these and some non-measurement criteria, indicate that the pregnancy is likely going to fail subsequently, usually within a few days after the ultrasound. But these are other uses of ultrasound measurements in pregnancy to determine in this case, prognosis. 7 millimeter embryo with no heartbeat, definite pregnancy failure. A 3 millimeter embryo with no heartbeat on the clip, almost for sure pregnancy failure. There's a teeny chance in this case that the pregnancy will make it, and no chance in this case. Even if I see a 1 or 2 millimeter embryo with no heartbeat, that's a very, very, very abnormal finding because it indicates a high likelihood of pregnancy failure. Mean sac diameter, again, has criteria for pregnancy, definite and suspicious pregnancy failure. Large yolk sac, as in this case, is highly suspicious, though not quite definitive, for pregnancy failure. And then a few findings that I listed that when there is a live embryo, in other words, an embryo with a heartbeat, when you see them, there's a high risk of subsequent pregnancy failure, including a large yolk sac measuring 9 millimeters. Anything over 6 or 7 millimeters indicates a high likelihood of subsequent failure. Slow heart rate, as seen here, at 64 beats per minute, is also indicating a high risk of subsequent pregnancy failure. One simple number to remember is that any heart rate in the early first trimester less than 90 beats per minute indicates a high chance of subsequent pregnancy failure. Another use of fetal measurements, not fetal ones, in ultrasound is in the assessment of poly and oligohydramnios. Here, the recommendations that I'll talk about come from a multi-society panel from a few years ago that came out with its final recommendations in this paper that was published in, actually simultaneously published in 3 journals. And again, multiple societies that were involved in this. I was one of the panelists on it, as are some of the other speakers at this meeting. The AIUM guidelines for second and third trimester say that a qualitative or semi-quantitative estimate of amniotic fluid volume should always be reported. We'll see in a minute what semi-quantitative methods of assessing fluid volume means. Sonographic assessment can be done subjectively or semi-quantitatively. Semi-quantitative methods include the single deepest pocket measurement or the amniotic fluid index, which is simply a sum of 4 different measurements. Here, subjectively, as we sweep through, it looks like there's too much fluid, and or you can measure the amniotic fluid index at 37.5, which is high, or take the largest one of these, 10 millimeters, as the single deepest pocket. I have to say, in our own department, we rely solely on subjective measurements. The only reason that I have an amniotic fluid index case to show is that I took it so I could put it in the talk, but we don't actually measure. We do subjective assessment. Subjective assessment is quick and efficient. It accounts, at least in a subjective sense, for gestational age variation in amniotic fluid volume. When I'm looking and sweeping through, either with my own hand and eyes or looking at a video clip, my brain has an expectation for how much fluid I'm going to see at that gestational age, and that's how I can subjectively account for gestational age variation. It does mean that it may be of uncertain reliability with an inexperienced operator, and it's best documented with a video clip. Deepest pocket and amniotic fluid index are semi-quantitative methods. I'll show you in a minute why, but they're certainly simple and quick, especially the single deepest pocket measurements. But there are some Downsides. The biggest one is that you can have a pretty thin pancake of fluid that may be big in 2 dimensions, but very thin in 1 dimension, just like a pancake, that has very little volume in it, but when you measure the deepest pocket and even look at it in a 2nd dimension, may look big. Biggest problem that I have is that they're really not at all mathematically valid. There is no direct relationship or even indirect relationship between linear measurements and volume. And what do I mean by that? Here are 2 human beings that have the same height, same single deepest pocket, and they have very different volumes. So they're not great. So what did the fetal imaging workshop recommend? That either a subjective assessment or semi-quantitative methods are both acceptable, either one of which, and they recommended the single deepest pocket over the amniotic fluid index because there are a number of studies that show that the single deepest pocket leads to fewer fetal interventions without any significant difference in outcome. This is a topic, markers of aneuploidy, that could take a whole lecture or a whole day, and obviously I'm not going to, but aneuploidy markers are findings that increase the likelihood of aneuploidy but have little or no significance in and of themselves, and they include some measurements like the nuchal translucency or fold, renal pelvis, and others, as well as some non-measurement markers. Urinary tract dilatation is yet another area in which fetal measurements play an important role. And here I'll be quoting from recommendations based on a consensus statement from a few years ago, from pretty recently. It's important to diagnose urinary tract dilatation in utero when it is there, because it's been proven to be able to lead to prevention of renal dysplasia and renal failure after birth if you know about dilatation in utero. And the key measurement is the AP diameter of the renal pelvis on a transverse view of the fetal abdomen. Here are different measurements and different degrees of fluid or amounts of fluid. By your eyes, you'd probably say this is normal, that's normal, that's normal, this one probably isn't, and those probably aren't as well. But the specific criteria are as shown here from the consensus conference. Between 16 and 28 weeks, anything between 4 and 6 millimeters is borderline, showing a mild increased risk of postnatal pathology. 7 to 9 millimeters is borderline. After 28 weeks, anything above those indicates a moderate to high risk of postnatal pathology, and below those is normal. Also, there's high risk if there are other non-measurement criteria, such as peripheral calyceal dilatation, parenchymal thinning, or abnormality, and others. Ventriculomegaly is yet another area where measurements are important. This is the easiest one. First of all, we measure it at the standard place to measure it is a lateral ventricular width at the level of the atrium, which is at the level of the posterior end of the choroid plexus. Even though this is drooping a little, it's completely normal. 6 millimeter is normal. Here, a big droop, and it's 14 millimeters, almost 15 millimeters. The reason this one's easy to remember is that there's a single upper limit of normal from 16 weeks onward, and that's 10 millimeters. Anything above that is mild or moderate or severe ventriculomegaly. Another measurement, distance from the placental edge to the internal cervical os in the assessment of placenta previa. Also from the fetal workshop that I talked about, the recommendation there was, and I think it's a good one, is the key thing to look at if you blow up this area is the distance from the internal os to the placental edge. Simple recommendations, don't use terms like partial previas or marginal previas. Standard terminology they recommend, and I like it, is if the placenta covers the os, it's a previa. If it's within 20 millimeters, but not over the os, it's low-lying, and if it's greater than 20 millimeters, there's no previa. And these are examples of no previa, low-lying, and previa. Cervical length is another measurement, and this is useful in at least some cases in assessing the risk of preterm delivery. Best measured on a transvaginal scan, and anything under than 2.5 centimeters, 25 millimeters, is abnormal. When there's funneling, the measurement is from the end of the funnel to the external os, and there are very specific criteria that have been put out there for how to measure the cervical length, and I won't go into them item by item, but it's an important, like all measurements, important to measure accurately. Fetal anemia, yet another area in which measurements can be important, and there the measurement that is most relevant is the peak systolic velocity in the middle cerebral artery. When it's more than 1.5 multiples of the median, it's predictive of fetal anemia, and that can be confirmed if necessary by doing a fetal blood sampling from the umbilical vein. How do you know how many multiples of the median you're dealing with? And this typical measurement is seen here, measuring this is the circle of Willis and the middle cerebral artery, getting the peak systolic velocity. And what do you do to get the multiples of the median? The simple way to do it is to go to this website from perinatology.com, put in the gestational age and the peak systolic velocity, and out comes the multiples of the median. Fetal compromise is yet another area where measurements apply, and that the rationale for Doppler and looking for fetal compromise is that many cases of fetal compromise are thought to be due to small vessel disease in the fetoplacental and or uteroplacental circulations. So elevated indices, and these are other measurement or number of elevated resistive indices or other indices are in these circulatory systems may be useful in the diagnosis of fetal compromise. An elevated systolic to diastolic ratio in the umbilical artery is worrisome. These are the what we consider to be elevated in our own department, anything above 4 before 30 weeks, above 3.5 at 30 to 34 weeks, and above 3 after 34 weeks are all worrisome or for fetal compromise. Absent or reverse diastolic flow are much more worrisome. So, overall, which measurements are important to do? In the first trimester, routinely measure the crown rump length. The early embryonic heart rate is useful for prognostic purposes. The nuchal translucency, I have to say, we do it on 100% of our roughly 10 to 14 week pregnancies. I put it in a different color because the AIUM, et cetera, guidelines suggest doing it only on a subset of patients. And in the second and third trimester, routinely measure the head, abdomen, and femur for age, weight, and weight percentile, the nuchal fold between 16 and 24 weeks, and 20 weeks, I mean. Always assess the fetal lateral ventricles, renal pelvis, and the distance from the placental edge to the cervical os. Either measure them routinely or at least look at them routinely and measure if there's questionable. And the amniotic fluid you can measure or assess subjectively. And a bunch of different uses of measurements that you can use, not routinely, but in specific situations. Well, I've come to the end of a long or a pretty long list of different uses of measurements. Numbers can be boring. I hope that I haven't set you yawning here. And I hope that it's been useful to you. Thank you for your attention, and